Thank you, George. Thank you all for being here. I know this is the early afternoon slot where maybe after lunch you feel a bit tired, but I hope we can energize you. So what I'm presenting today is the result of 5 years of work, and I'll start with a thank you to the Basel Center. I think this work would not have been possible without them, and it's a true pleasure to be here and report back what we've learned in this time. This is joint work with Investigator, and Adriana is here. You will meet her later, who founded this with Universidad Peruana Cayetano Heredia in Peru, with the Harvard Graduate School of Education and ETH Zurich. So thank you already. Here is a list in alphabetical order. I'm delighted to have 3 colleagues here with us today. You'll find them on the list. And you can see a little team visit in Peru at the bottom right, and you can see our weekly calls online. Those were part of our life. I think we start to miss them a little bit now that we are done. It used to be every Friday our call and moving things along. So a little outline, I will just give you a bit of background. I mean, you've heard so much about early childhood development already today that I don't need to spend lots of time on it, maybe just some global numbers. And then explain a little bit the objectives. I think this is not a clinical study. We were very much population-based. We were trying to figure out whether an AI-supported intervention can actually work at scale in real-life settings. I'll describe the settings, show some of the piloting we did, and then show you some of the results. I think the background is quite familiar to most of you. The Lancet series came up with this 250 million number. You can challenge the number if you want, but I think we can agree that there are many children today that are not reaching their potential, and we are all trying to come up with new ways to support the children and their families. And the need to do something, I think, has now been well recognized. SDG 3 and SDG Target 4.2 make it explicit, and in the field, especially for under 3 children, the consensus is that parenting interventions are the gold standard for improving health and development for children under the age of 3, or the first 1,000 days, if you prefer that term. And the challenge, of course, is that in many settings, home visiting programs are not easy to implement. I'm guessing some of you have been personally involved. It's quite a process. It really requires resources and quite a bit of planning, quite a bit of staffing, and is therefore not possible in many settings. The good news is that we now have mobile phones almost everywhere. In Peru, actually, we don't just have mobile phones, but we have a quite high share of smartphones, as I will show you in a second. And these give us quite easy and cost-effective ways of interacting with parents. I think that's the background. And in this project, we were trying to assess through a trial whether these mobile phone-based interventions can really offer an alternative for improving child development in low-resource settings. I think you all have seen these graphs. You know, mobile phone coverage is almost universal, even in the poorest settings now, even in the DRC and Nigeria that Liz has mentioned. I think we now can reach most of them. There is lots of smartphone coverage increase. That's, I would say, more from middle to upper income, maybe not the poorest yet. But even for the poorest now, we have often these mini data plans. So I think for a while, the poor had just these prepaid phones that just had voice. But now increasingly, we have these like mini data plans that allow a minimum of, at least you can send images, like you can send some basic videos. And I think we can use those to interact with families. So here comes Investigator, and if you have any questions on it, Adriana will be delighted to talk more about it. I think the idea was to develop like a platform essentially that allows us to interact with families in a way that can be done on quite basic phones, that's easy to understand for parents and encourages parents to interact with the child. There are 2 key features. Number 1, there is a chatbot, which, Adriana, I'm sure you will agree, when we developed was very basic compared to the chatbots. This was 2019, so it seems almost silly today, I think, what the chatbot could do, but I think it was responsive to parents, like it was able to answer, and then in the background of the system was a machine learning algorithm that picked activities. So I am not sure how familiar you are with parenting programs, but a typical parenting program involves some kind of community health worker that goes to the home and then has an agenda for the visit. Like I would say the most famous maybe Reach Out program has typically a song, like a toy that you interact with, and then some tasks, like some things to do for the next week or the next 2 weeks. So we would do that through the app, and the app was designed to be smart. So essentially learning over time whether parents liked or did not like an activity. So at the end of the activity, the app asks like, okay, was this fun? Did your child like this? And therefore trying to guess what the next activity would be that the parent and the child would enjoy so that users stay engaged. So this is how like an interaction would look like. It's just a simple screen, essentially like a chat window. Hi, Anna, this is your virtual tutor. Let's go. Like this is what we can do today. And then here is an activity. Let's play with cubes today, for example. So you have like something you can do and like sit down with your child. And it describes the materials, but also the learning objectives. Like not just do this, but like why are we doing this? Like we're trying to help your child learn, like shapes, colors, and there's a clear learning goal. Any questions on the platform? You can also install it if you want. You can try it out yourself. I think Adriana, it's still freely accessible, right? Okay, perfect. So in this project, it was okay, like we have this platform, and when I met Adriana almost 10 years ago, this platform, I think, was like on the way up and had more users, but having more users doesn't always mean it's actually useful for everybody, right? Like users self-select and they're like, okay, it's nice you have all these users and they love you and like they're happy, but how would this look if we would use this like as a public intervention? If we actually go out to poor communities and say, okay, look, here's an app that you might like. Can you please use it? We'll try to interact you, and like the app will help you to have fun with your child. This was the idea. Like not wait for users to come, but we would go to users, introduce them to the app, and then measure how many of them are willing, able to use the app. That's the first step, of course. If they don't like the app, we are dead, essentially. But assuming that they like the app, we can measure how long will they use the app, and does it actually improve child development? Like that's the ultimate question that we were asking. Where did we do this? Well, it's Cajamarca region in Andean Peru. If you haven't been, here's a little image. It's beautiful. It's high up in the mountains. The base is about 2,000 meters. It goes up to almost 4,000. So it's hilly and dry. We worked in 3 different subregions, which I'll explain in a second. And we started with a pilot and then went into a full-blown cluster-randomized trial where we split the sample into control, kind of the gold standard home visits, and then the Affini intervention to see how they compare. Here's like another screenshot. So the 3 provinces that we worked were San Marcos, Cajabamba, and Cajamarca. Probably only relevant to those of you who know Peru well. They are on the map, kind of like on the north inland, I guess, in the mountains. The range I already described, and most of the population engages in farming. I think there's a bit of services, but it's a typical rural Latin American setting, and I think you could find similar populations in many parts. Here you can see it on the map. So where are we? So I would say north, slightly inland, and here on this second map you can see all the clusters. So cluster was for most parts a village, just a rural village, and in the 3 urban places we divided the city into kind of little sub parts, like blocks, I guess you could say, and the treatment was randomized at that level. So before we jumped into the trial, of course, we wanted to make sure this works. So we went out and first looked for parents who have young children. I think that was the first step. And we found 180 mothers for the trial. We chose age range 2 to 24 months. And of course, we made it conditional. You need to have a smartphone or like semi-smartphone so we can work with it. Then Affini had already lots of content, but we were quite worried that like some of the content that came from Guatemala and then we had content from US like might not be suitable for rural Peru. So we had a large team going through activity by activity. Okay, what if we propose this, I mean, the cubes, I think, is non-controversial, but let's say we have an activity that involves drawing something, like would that be appropriate for this population? So we made sure that everybody was okay with all the activities. We confirmed the suitability and then developed a few additional items that just came up. Okay, like, why don't you also propose this? And I think we came up with an activity database, which I think is now quite comprehensive. Second, we were at the beginning quite nervous, like, okay, how many of these communities actually do have the right phones for us to do this? And here, I think we were quite pleasantly surprised. So we went out to 142 communities. The signal strength was what we needed in 136, so almost everywhere. And more than 90% of moms actually had a phone that was like smart enough to do what we wanted, which means just able to do the messenger. Like, you don't have to do full-blown like iPhone online serving, but like just enough to interact with us. What was also very striking to me in this rural and not highly educated population is like how much they were online. I think we asked like, okay, to use Facebook, to use Facebook Messenger, and like you can, sorry, I'm blocking you here. You can see that for all platforms, it's like 95 to 100%. Like this population really uses like social media, and you can have lots of concerns. For our study, that was great news. Okay, like, well, great. Like, we know how to talk to you. We are not sure you should spend so much time on these platforms, but please spend time with us. I think that was our message. Yeah, as I said, like we added some new photos, you know, like made sure that children look like local children. We made sure that like parents understood like how this worked. Like we also designed a little booklet that would help parents like with instructions, like how can you access. And over time, we also added additional channels. I think initially when we started, this was all Facebook Messenger. But then over time, we had some issues with Facebook. They're actually not so nice to work with. And we realized that moms actually use WhatsApp more than Facebook. So we introduced a second channel. I mean, as you can see from the chat, like it looks the same, just going through WhatsApp. And then Affini also developed an own standalone app, so you could just install that and like text through that. Like I don't think that was the winning channel, but WhatsApp I think was definitely quite valuable because then we could reach them quite easily. In the background, I think this was the work of Team ETH. We did systems adaptation, so we tried to optimize what the system was doing on the back end. So whenever we got a feedback from the parent, okay, I did not like this activity, or this my child did not like, it would go into the system and the system would over time become smarter. Okay, like so this child is now 15 months old, a girl, didn't like the last activity, so let's try this. So this recommender system in the background, we try to improve over time. Then after we had made sure this worked and had convinced ourselves that this phone coverage was sufficient, we went to a full-on cluster-randomized trial. We enrolled 2,461 parent-child diets. They were allocated control, Affini, and then a smaller group to home intervention, because our prior was the home intervention would have substantially larger treatment effects as suggested in the literature. I think I can skip the rest here. If you're wondering about number of clusters, so we had 68 villages or clusters in the control, 19 for the home visits, and then 72 for Affini. I think the statistics are kind of what you would expect. We had about 8% low birth weight. Average age at enrollment was about 5. Average age of the mom was about 28. And I would say, compared to other countries, middle level of education. I think definitely not the DRC, but definitely also not the US, let's say, like somewhere in the middle. So first thing, now that we had enrolled parents, of course, we were wondering like, okay, how much do they stick with the app? Okay, like we can come to the home and say, look, like very cute, we have this, we'll help you set it up. So like essentially our field workers set it up on the phone so we could reach them, and then we could reach out to them and give them information. So of course, mechanically we start at 100% here because that's just the first week when we come and say, okay, let's connect with the system, and then the system connects back. But you can see in months that the use, like, I mean, didn't go to 0, but it went down quite a lot. So when we first saw this, like, okay, so within 3 months, I think we were down to about 40% on average, and particularly low, like here we split the sample into those who have their own phone and those where you use another family phone. So if it's not your own phone, of course, then it's trickier to access the system and we see a steeper decline. But even for the ones with their own phone, by month 5, we were below 50%. So it's not that everybody loves it and sticks with it, but because once again, this is not people who come and look for the app. Like this is people that we kind of push the app to, and I think 50% I think is quite respectable, but clearly fading over time. So then question, okay, like if we lose them after 5 months, our end line is after 18 months, what will we find? So we were quite nervous, but here it comes. The good news is the app actually worked. So even though our compliance was far from perfect, I would just focus here on the adjusted models. We see that home visit intervention had roughly a 0.2 standard deviation improvement in child development, and we get about 0.11 standard deviations for the app. So depending how you want to scale it, like roughly 2/3 of the effect with the app. And for secondary outcomes, we look at mental health, we look at self-reported child development. We don't see much for either intervention, so I think also comparable for that. So big picture, roughly like 2/3 of the treatment effect with the app versus in person. No big impact on other things. We were also quite nervous about which populations are we reaching. I think actually even when we presented the project a long time ago, it's like, well, will you not just reach like the better off moms and they will like this app and they will benefit, and like you will kind of lose the lower end of the spectrum, and we don't find that. Like we analyze here both by like maternal age group and by household asset quintile, and I mean this is quite noisy, but there is no clear signal. I would actually say maybe the best of households and the worst of households for some reason had the best, but I would say it's just flat. Like I think we see improvements across the board, and I think that holds both for home visits and for affinity. I think like there seems to be no clear difference. Now, of course, for policy, you don't just care about impact, but you care about cost. And the cost calculation, I think maybe that's obvious to all, but I think it's quite clear. So home visits are not cheap, because I think the rule of thumb is that you need for every 25 to 30 children, you need a health worker essentially. And in these rural communities, you need also a motorbike, you need to get around, you need the materials. So home visits are not that expensive. So not that cheap, I want to say, sorry. So total cost that we compute for 18 months of programming is $650 for home visits. So, I mean, not crazy, but I think it costs. And for the digital interventions, even if we count some of the staff, some of the equipment, we get to about $40. So in terms of costs, for 18 months of programming, the ratio is about 15:1. Yeah, so 2/3 effect size versus 15:1. I think it's not a very complicated calculation. And then you can also do the cost per standard deviation increase. If the metric is, okay, we want to improve standard deviations, the ratio is about 10:1. Great, that already brings me to the summary. So good news is that we do have today a very large population in quite resource-constrained settings that do have access to phones, increasingly semi-smartphones and smartphones, and I think we should use that. I think we have a way now to communicate with many populations. The new technologies, I think that changes every day. I think we've also learned that it's not easy to keep people engaged, and I think if you're an app developer, probably you're not surprised, like people get excited and they do use it for a while, but then here comes another app that's cooler, or like you try out something else quite fast. So I think we should anticipate that people will not just love the app and use it forever. So if we want to change behavior, I think we need to get people in the habit quite fast. And I think what happened in our study is that, okay, on average, people were gone after 4 or 5 months, but I think by that time, they had already understood the main logic, right? The main logic is, okay, think of something fun with your child, like think to spend time with your child, think to engage your child, and these behaviors then are, it seems, persistent enough over time that we see treatment effects. We found like 0.17 versus 0.11 standard deviations, no clear evidence that either intervention clearly favors any specific subpopulation. So if you're worried that like the less educated moms or the poorest of the poor benefit less, like it doesn't seem to be the case. It's quite, actually with Lena, I think we were trying quite a few models to figure like who are these people who actually benefit, and it's almost impossible to predict who sticks with the app. It just seems some people really love the app and they engage more, and some people just don't like the app as much, and I think they do what they want. Cost effectiveness, if that's the question, we don't need to discuss. I think it's quite clear. Just like a few notes and limitations. Clearly, this was just one specific setting, one specific populations, and I think we need to have more studies like this to see how well it would work in South Africa or in DRC or in other settings. I'm quite sure it will work, but I think we have to work and adapt interventions as we need. And to me, like why I'm so confident and also listening to the presentations here, these systems have become so much smarter. I think to me, when I look at what we did, it seems like now 50 years ago, even though it's just 5, just because things develop so rapidly that today we have tools that are much more powerful than what we had. And I think with these tools, we can provide much better customized, personalized support to families than we were able to do. And I think families will like that. So we get more powerful in that sense every day, and I think we can and should use that. So I'm very confident that the next generation of these interventions will be more comprehensive and not just have more fine-grained recommendations, but can also offer other services to moms, and maybe mental health is the obvious one. I think in my studies, often what we see, one of the primary risk factors for poor child development is maternal mental health. And I think we have now quite a strong evidence base that online systems can provide help. And I think if we can integrate those in a package, maybe the impact will be even larger. But that's for future research. For now, I will just say thank you, especially to the center, to everyone here, and I'm happy to take questions.